All right, Julie, are you going to go first today?
It looks like it.
Okay.
Okay. Well, I think everybody knows me, but I'm Julie, the dietitian here at the hospital, and just going to kind of give a recap. I think, you know, it's fairly obvious what dietary does, but just kind of review, I guess, more kind of looking at the numbers and seeing the kind of services we provide. As you all know, the department is staffed 365 days a year from 5:30 to, usually someone is here till 7. Primarily they're doing dishes from the 6:15 to 7 o'clock time frame and cleaning up the area. Cafeteria is open from 6:30 to 7. We serve breakfast, hot breakfast 3 days a week, but we have a variety of continental items that are available every day. And then, of course, the dinner and lunch and dinner, I guess, if you're a city person. I'm a dinner and supper type of gal, but either way you want to look at it. So, of course, what are the areas of service that we provide? We, of course, provide meals to patients, and based on their prescribed diet, of course, by their medical practitioner. I do a lot of education on special diets for inpatients and outpatients. We serve a lot of coworkers, of course, in the cafeteria. That's actually the largest volume as far as the volume of our services. Of course, to meetings, and then do various well-you events kind of through the year. We, of course, any visitors is welcome to dine in the cafeteria now. We were closed through COVID for a very short period of time, well, longer than we wanted, but we're now pretty much reopened. Slowly, our coworkers are coming back to eat in. Still, many I think are in that realm of it's easier to just take it and go. So we still have a lot of to-goes that are going out, and then to visitors, of course, we provide a lot of guest trays and those kinds of things throughout the year, as requested by other co-workers through the building when there's a need that arises. And then I also help with the customer service component here at the hospital. With that, it's the patient satisfaction. Currently, we work with Press Ganey. We're talking about looking towards another vendor for just kind of hopefully to increase the volume of responses that we get, as well as be most effective as far as the cost that we're incurring as a facility. And then with that, I also help with the employee engagement annual survey that we do. The last few years, we've done a self-operated tool that through SurveyMonkey, that they kind of do all of the analysis for us, and that has worked pretty good, at least to get us some information for managers to kind of know what areas do we need to be working on to continue to hopefully work towards more staff satisfaction, which is just kind of an ongoing process that I think any good organization would work towards. So as far as the volumes, this is a very busy slide, but it's got the last 5 years just to give you an idea, and we are not back yet to the pre-COVID numbers, but it's certainly on the rebound, I think, and in the way of getting there. So the patient meals actually have exceeded what at least last year's fiscal year was, and this is fiscal year 2021. I was going to put the 22 data so far, but it really didn't look right on the slide, so it didn't make sense to include that. So. And then I also am part of the Certified Diabetes Education Program. Jan Hastert and I work together doing that. Jan, as you may know, has been here also for many years. Jan is also a health coach at the clinic, and diabetes is actually supposed to be about half of what the time, or a little more than half the time that she does, because there are so many patients that we work with that have diabetes. We did just get notification in January of this year. We had reapplied for our national accreditation, which is actually what you need to have to be able to bill the services. But it's more than that, just making sure that you're kind of a well-rounded program and covering all the aspects that they require for diabetes self-management training. So I think that's all I have. Any questions anybody has for me?
It did get renewed then?
It did, yes. Mm-hmm. Yep.
Questions?
Okay, thank you.
Thank you, Julie.
Thanks, Julie.
I'll try to spaces, Julie. Perfect.
All right, good morning. I'm Kim.
Good morning.
From the clinic, for those of you who I guess don't know who I am. And we're just going to do a real quick overview today in regards to what we have at the clinic and what we have to offer. So just a quick refresher, medical staff, we do have 7 family practice, which is either an MD or a DO. We do have 1 internal med, which is Dr. Devine. She's also duly certified in pediatrics. Dr. John, the podiatrist. We do have 4 advanced nurse practitioners and 3 physician assistants covering all 5 of our clinics. Our nursing staff is comprised of those that work in the pods directly with the physician, our phone nurses that help the customers that are calling in for questions or calling back with results. We do have float nurses to assist with keeping the workflows at a nice steady pace, and on those heavy days, trying to keep the wait times down. We do have an immunization nurse, and this is 100% for quality and ensuring patients stay up to date with all required immunizations. We do have 3 health coaches and a 4th, if you want to call our INR nurse, who watches over, and that's been a great service to our providers. We do have a refill and a PA position, as well as our satellite clinic nursing staff. We do have 3 current needs that are out there. We are on the hunt for a pod nurse, as well as a phone nurse, and then a satellite nurse. So if you know anybody, I'll put my little plug in, send them our way, all right? We do have the 5 locations. Avoca is open 4 days throughout the week, Tuesday through Friday. Erling is open every day with the exception of Thursday. Elkhorn has hours on Monday, Tuesday, and then Friday mornings. Harlan has 7 a.m. appointments, so we are here 6 days a week, Monday through Saturday. We do start with 7 a.m. appointments. We do offer lunchtime appointments for those that are working and need some time away at that time, as well as evening clinic hours. And those are a very popular item amongst this community. There's not too many times that those appointments are left unused. And then the Shelby Clinic is open Monday, Wednesday, and then Thursdays 2 times per month. We do have a provider that goes over 2 times per month.
Are you still open on Saturdays also?
Yes, in Harlan,
Some morning.
8 to 12. Yep. Just kind of a quick little overview. So you can see from 2019 to 2022, we were right around that 31,000 visits. That was pretty normal for us. This was definitely the pre-COVID everything. We focused a lot on preventative visits. We did a lot of annual wellness, well child visits, and then we also wanted to see our folks that had chronic disease to help with that maintenance. You can see in 2020 we did dip down just a little bit. We were doing some wellness and prevention, but this is kind of when we were kind of expecting those that were well to stay home. And then you do really see a significant drop in 2021, and that's kind of when we were in the heart of everything. We dipped clear down to 26,000 visits. We were doing very, very minimal preventative services at this time. Those that were well, we wanted to keep them well, so they were staying in their homes. We did not have as many of the chronic care visits at this time. Most things were just strictly acute care, and a lot of it was just COVID visits. Then 2022, you can see we're bumping back up, 31,000 again. We're staying busy, there's no doubt about that. We're definitely getting caught up on all the prevention that we missed out on over the last couple of years. So very happy for that. Patients are pretty happy to be getting back to normal too. We have some of them calling in for that annual wellness visit, so very nice. Our current focus, we're continuing with our ACO measures, kind of all about quality. So we do focus on diabetes. We do have goals around hypertension. We do depression screenings. We want to make sure that we can offer treatment if necessary, and then if we are offering treatment, we want to make sure that somebody is entering into remission. We do fall screenings to make sure people are safe in their homes. We're watching over influenza vaccine. We do tobacco screening, watching the breast and colorectal cancer screenings, definitely encouraging that at the recommended time frames for everybody. And just to put in there, 45 is the new screening time for those with colorectal cancer screening. It used to be age 50, it's now bumped down to 45. Statin use for certain reasons, patients need to have their cholesterol under control. And then we do watch over problem lists. We want to make sure our patients have an accurate list, as well as we have an accurate list of your medications and allergies on hand. And we strive, which our numbers have really significantly improved, as Laura can attest to, our after visit summary. We're wanting to give a paper copy Or if somebody signed up on My Chart, it will automatically go into their My Chart and they can look that up online. But it's everything about their visit from that particular day. We're also focusing on health coach visits, and this is with chronic care management, so any of the COPD, congestive heart failure, diabetes, and then hypertension as well as they are doing a really big push for annual wellness visits, and this is the Medicare covered visit that is not the head to toe, but it's more of a preventative, come in, just have that nice casual conversation with your practitioner and plan out for your future. And then our other focus this year is the patient satisfaction surveys. In July of this past 2021, we did change from telephone calls that were going out, as Julie had alluded to previous, to paper surveys, and now we are internally doing that within our department. And we've had pretty good response so far. So with that, if there's any questions surrounding the role, I'd be happy to answer.
I wouldn't mean to put you on the spot, but what would you think your biggest challenge is?
Our biggest challenge? Overall, would you say with patients or maybe staff or either? I would say maybe one of the biggest things, just because it's clear on my mind, one of the biggest things is trying to get understanding about Medicare. We do have a very large Medicare population. You know, we're, I believe, 50%.
Yeah.
And so the commercials are out there. Let's go ahead, let's do this annual wellness, and everybody's hearing that you're entitled to this. But it's not your typical visit.
Right.
So this is the visit where we just want to come in, we just want to talk with you, we want to know who do you see, who's your care team, whether they're here in Harlan, you see specialty in the city or wherever it is that you see them, and just making sure that our records are completely up to date. And it's talking about advanced directives, it's talking about, you know, safety in your own home. That's probably the hardest thing to right now get our Medicare folks to agree to come in and do these visits. They want to have them, but they want their practitioner to be able to lay their hands on them and that type of a thing too. And so we just keep educating and educating.
Thank you.
Yeah.
Anyone else? Thanks, Karen.
Thank you.
Thanks.
Okay, I think we're ready to call the meeting to order. I'm sure you've all had an opportunity to read the minutes from February 22nd. If I could get a motion on the approval of those.
I'll make a motion.
Thank you, Jim. Second?
I will.
Whoever Ruth got down. All right, all in favor, say aye.
Aye.
Okay. Moving right along, the medical staff meeting summary. It looks like Karen's going to update us on that today. There she is.
So Dr. Markham is at the trauma case study today, and I think you've heard about 4 times a year we try to do the trauma case studies, and we try to do them on the 4th Tuesday of the month, so that's why this happened to coincide today, so sorry you couldn't come. But medical staff meeting was March 8th. We went over, Adam Porter, one of our pharmacists, came and joined the medical staff, gave a short presentation on some of the shortages of medications we have out there right now. Solumedrol, which is a steroid, is one of them. Now, some of our emergency medicines, now we have enough, so I don't want anybody to worry, but they are at a shortage at this point, so we're trying to keep up on that. And then he went over and did a little bit of a presentation on D50, which is one of those emergency medications. It's basically a high dextrose or sugar concentration for our diabetic patients if they have a low blood sugar. So he went over how we can use D10, which is just a lower concentration of that in the same way if we don't have enough of the D50. So went over that with the medical staff. He also went over a new medication out there. It's phosphomycin, medication that can be used for recurrent urinary tract infections that are resistant to other antibiotics. So it's a new one out there. He went over with them. Elective surgery, anesthesia guidelines, post-COVID-19 infection policy. So Ron K., one of our anesthetists, came in, our CRNAs, and he went over, we've been seeing some COVID patients or post-COVID, they've had COVID in the past, and as we know, it's a very respiratory type of infection. and they don't do very well after surgery and anesthesia. So there are recommendations out there now that we wait a certain amount of time from when they've had their COVID infection to when we actually do surgery to have better outcomes after surgery. So some new guidelines with that, anywhere from 4 weeks to 12 weeks post-infection, depending on the person and how bad they had the COVID infection. So these are all guidelines from the American, it's basically their ASA, it's their kind of like American College of Surgeons, it's their guru. So that's where they got all those guidelines. Medical staff did approve that policy then. We went over the joint conference policies and procedures, which I will go over with you guys this morning. And then Infection Prevention Committee did go over CMS requirements for employees to be vaccinated against COVID-19. So basically we did a lot of looking at that in the Infection Prevention Committee. And everything else was under Barry's report. Any questions anybody has on that stuff? Thank you.
Laura, quality improvement report.
Okay, I'm just going to go through a few of the quality, the departments that reported at the last quality meeting. Behavioral health reviewed documentation compliance, which was nearly at 100%, and also their satisfaction surveys. On the question that was, would you recommend our department or your practitioner to a friend? That was at 100%. For the business office, they monitored accounts receivable days. The goals that we have for that are 55 for hospital billing and 35 days for professional billing. And we were at 56 for hospital and 28 for professional billing. So right at our goal or below. For diagnostic imaging, they had no image rescans, and they also had no infiltrations for MRIs or CAT scans during the time that they monitored. The emergency department, they kind of look at door to transfer time for heart attack patients. For the last quarter, we're at 38 minutes. The national average for that is 61 minutes. So we're well below the national average on that. For environmental services, they just make sure that the sharps containers are emptied at half or 3/4, and they were doing very good at that. For health information management, they reviewed documentation compliance as well, which was nearly at 100%. Human resources looked at assuring forms are updated and according to all the state regulations. And then IT monitored ticket compliance for if you have a problem, you put in a ticket for IT, and they were at 86% compliance for that. And that was meeting their goal. And that's all I have.
Thank you. Approval of the Joint Conference Committee policy and procedure revisions. Karen,
All right, I'm back again.
round two.
All right, I'll pass around. These are all the actual policies and procedures. So, Joint Conference Committee met on April 14th, and basically we do two things in this committee for policy approval. We look at full policy and procedure manuals we divide the departments up 4 times a year. So the departments that we were looking at, they bring all of their policy procedure manuals, and we review those. And then we also look at the policies and procedures for the last quarter, so the last 3 months. So the departments we looked at for the full year were administration, business office, emergency preparedness, laboratory, and laboratory has 9 policy and procedure manuals for each of their different things that they do. So even though we say lab is a nice short little word, but it's 9 policy and procedure manuals. Senior Life Solutions, and the last one here. Yeah, and then Senior Life Solutions is actually the last one. So kind of a short one, but short even though Lab had their 9 manuals. So those were the full year ones. And basically when I go over the quarterly ones, those are all in these full year policy and procedure manuals. So I'll go over a little more in depth in those. So the quarter ones were October through December of 2021. Policies and procedures we looked at for human resources. We had some hiring bonuses and COVID bonuses that we were offering staff, so those were reviewed with human resources. Infection prevention, obviously, again, was always COVID-19. She had her COVID policies we looked at. Also looked at using IRIS in our electronic medical record. IRIS is a state repository, basically, for vaccines that everybody's vaccines go into, so that if you ever need to know what vaccines you've had, you can go to that. So have that in our policies and procedures to look up vaccines. And again, a lot of assessments with the COVID vaccine coming out during that time frame and utilizing that.
Nursing administration, again, we had some incentive guidelines for staff working. We included our CNAs, our certified nursing assistants, in those incentive guidelines. Public health, always looking at their China HIP, their annual survey that they do, and going over that every 3 years, looking at social determinants of health, and did some updating of a supervision policy. Quality improvement, basically just some wording changes that were addressed in other policies. So they were just deleting any duplications with those. Kim talked about the rural health clinic, mostly going over a survey that they had for that. And safety manual, a couple things where we looked at fire, the fire drills that we have and how the rural health clinics are performing their fire drills as well as the hospital fire drills. And then we did kind of a deep dive into severe weather. We were trying to look at some of those safety policies as they're coming up. So as you know, we're coming up in the spring, tornadoes, etc. So we did a deep dive into our severe weather policy. And basically we used to have that EMA would notify us of tornadoes and those type of things. And we've gone now to where you can use the Alert Iowa system and get that on your phone. So staff are encouraged to have that on their phone so that we know if any severe weather is coming out. So those are all the policies and procedures. They have gone through the Joint Conference Committee. They go through the full medical staff, and it was approved in medical staff, so then it comes to the board for approval at the board meeting. Any questions you have? Otherwise, I would need approval of those policies.
Questions? Okay, we've heard the Joint Conference Committee policy and procedure revisions. If I could get a motion on that, please, for approval.
I'll move to approve the revisions.
Thank you, Terry. If we could get a second.
I'll second.
All right. We've got a motion and a second on the Personnel Committee, oops, wrong one, Janine. On the Joint Conference Committee policy and procedure revisions. All in favor?
Aye.
Opposed, same sign. Thank you. Thank you, Karen. Okay, Mr. Zimmerman, it looks like you're going to present us with the Personnel Committee report today.
Jim? Oh, there were 2 initial appointments, 6 reappointments, and 1 voluntary withdrawal. And I will make a motion to approve those.
Okay, we have a motion. If we could get a second, please.
I will second it.
Thank you, Liana. Motion and a second on the Personnel Committee report. All in favor?
Aye.
Thank you. Opposed, I guess. Barry, it looks like we're ready for the CEO report.
So I just wanted to give you an update on a few things we've been working on. Start with the general surgeon recruitment. We have hired a recruitment firm, Jackson Physician Search, and the position has been marketed for a couple weeks now. We've had 4 individuals contact us. A couple of them were within 90 miles of Harlan, and the individuals weren't really willing to relocate. So we moved on, passed on those 2. We have had a couple other applicants, and we did do a Zoom interview with one of them last week, and we'll be setting up another interview with the other candidate here very shortly. So we do have a couple candidates that we're looking at as of now, and I think I may have mentioned in the past that we have talked to temporary locum tenens agencies. If we do have a gap between Dr. Bendorf and our new general surgeon, we will look at hiring somebody to fill that gap, a temporary locum tenens during that period. So that's kind of our update on general surgeon. A couple other providers that we're looking at right now, CRNA. Can't wear my glasses and my mask at the same time. So CRNA, Wade Bloomhart left about 6 months ago, and we've been using an agency during that period to fill that position. We have a couple of individuals that we've interviewed one and have another one that we'll interview here in the next couple weeks. So hopefully we'll be filling that position here very soon. And I talked a little bit about rheumatology. It's one of those specialties that we've we've really wanted to fill for quite some time. We do have a couple opportunities right now with a rheumatologist out of Omaha that we did interview here a couple weeks ago. She did a site visit. And the other option is potentially working with Atlantic. Atlantic and Creston have joint employed a rheumatologist, and there is a possibility that we could get that individual here a couple days a month. So we're still working on those two options. I believe that I've mentioned the fact that we did have a home health consultant review done here recently. I think they were here actually on site a couple weeks ago. And we're waiting for the final report on that, but we think we're going to get some good information out of that consultant that we can use moving forward. So I'll have more information on that once we get the final written report. Accountable care organizations, we're evaluating where we're at with our current ACO. We've been with Harlan Health ACO. It's a Medicare accountable care organization. We've been with them for about 2.5 years now, and when we chose to go with them, we had two options. Harlan Health, which is more of a local, smaller ACO, and then Caravan, which is a larger national Medicare ACO. The smaller, the ACO that we've been with Harlan Health, we haven't had any shared savings in the 2.5 years that we've been with them. 2023 will require us to take risk, which means that not only do we get to share in savings, but we would also get to share in losses in 2023. So it's a little more concerning now that we haven't seen those shared savings the last 2.5 years. Have some concerns about an ACO with only 7,500 attributed lives in comparison to the Caravan ACO, which would be much bigger, as much as 100,000 attributed lives. So some concern about the structure that we have with such a small ACO and whether we're ever really going to be able to realize some of those savings. So we do have and one of the other changes that has happened in the last 3 years since we made that decision is the Caravan ACO no longer has a monthly fee, whereas the Harlan Health ACO, we still pay a monthly fee. So we're considering what we want to do moving forward. We do have to make a decision here fairly soon. We have a meeting with our internal staff that are on that ACO committee this week to discuss it, and we're also going to have a call with Caravan this week as well with that same group. So I just wanted to let you know that we're working on that and considering making some changes with regard to our ACO. We've done a lot of really good things with this ACO, but I think a lot of it is because of what Kim and the health coaches and Laura and Ann have done internally, more so than what we've been getting from the ACO itself. It does provide us with a structure that helps us with some of those metrics, but I think a lot of the work and a lot of the benefit that we've seen in improved patient care has been based on the work that our staff have done internally. So there'll be a little bit more to come later on that. I did want to just give you an update on legislative activities. So tort reform is still out there. I have to have my glasses here. It's kind of stalled a little bit, and when we talk about tort reform, what's being proposed or what's in the bill is moving to $1 million non-economic damage cap. So non-economic damages are pain and suffering and emotional distress, and those types of damages. So $1 million cap. Just recently here in the last couple weeks, there's been a jury award in Iowa City of over $90 million on an OB case. So this is what's kind of driving us forward for looking to get this kind of cap put in place. But it's been stalled a little bit. It is eligible for floor debate. It sounds like the Senate is in favor of moving forward, and the House is really more undecided at this point, and they're really going to need to make a decision or have the debate here within the next couple weeks for it to happen. So we'll keep our eyes on that over the next few weeks. Certificate of need is the other big area for hospitals, and the original bill that was introduced was defeated, and of course we're, from an IHA and from a community hospital standpoint, we want CON to continue, certificate of need process to continue, but there has been additional bills introduced. The most recent one is excluding birthing centers and behavioral health services from the CON process, and then increasing the threshold for requiring CON from 1.5 million to 5 million for buildings and 1.5 million to 3 million for equipment. So again, that's still out there. It could potentially move forward. We've done quite a bit of advocacy, some advocacy efforts with all IHA as well as a lot of the healthcare CEOs in the state with both tort reform and CON efforts. I guess the other one that's out there right now is the governor's workforce bill. Likely that will get passed, but a lot of it has to do with loan forgiveness or loan advances for healthcare professionals. So I think there definitely will be some benefit with that program. So those are the main areas on that we're looking at from a legislative standpoint. There is one other item that it's been passed in both houses, but it's on the governor's desk basically to be signed, and that's this construction management at risk, which has never been available to public entities in the state of Iowa until now, assuming the governor signs it, which we think she will. It'll go into effect July 1. It's something that we could utilize in our ED renovation project and would like to. So basically, in the past, construction management agency has been available to public entities in Iowa, but never at risk. So really it allows us to kind of replace a general contractor with a construction manager that we would be able to bring on earlier in the process and choose based on qualifications, as opposed to waiting until bid day for knowing who our general contractor is going to be. So we would like to be able to use that. We're kind of working with USDA on this right now, and they're kind of questioning whether the project is large enough to utilize a construction manager. We think there's a lot of benefit to it. So there's probably going to be more to come on that, and maybe this ties a little bit into our next discussion, which is related to the emergency room project. So maybe we could put that PowerPoint up, and we'll go to the next one. So as you know, we received the USDA grant of $1 million in January. So we've been working on this, and this ED has been part of our master facility plan for the last 3 to 4 years. It's kind of risen in its I guess on our list of things we'd like to do. It's kind of gone up the list, higher up the list over the last few years with COVID and our increase in volumes in the emergency room department. So, in the grant itself, the USDA grant itself, the ED, it made more sense. We had a better chance of, I guess, getting that grant, using it toward, having it go towards this ED renovation. So I'm going to turn this over to Jeff and Karen to kind of talk about, Karen will talk about really what we're trying to achieve with the improvements from a nursing standpoint. And Jeff will talk a little bit about the facility itself and kind of what our timeline and what our process should look like. So I don't know which one of you are going to go
Karen's
first.
going to go first.
And I think, Barry went over a lot of this at the last meeting, but just to kind of go over, the timeline is up there. Hopefully we'll outfit it this fall, construction next spring, and due to the grant, we have to have this completed by 2024. So some of the things we're trying to look at, as Barry mentioned, with COVID-19, we really wanted, this really came to fruition at that time, but better segregation of our infectious patients from our non-infectious patients. So basically, somebody infected with COVID or any other virus versus somebody who, broke a bone or has to have stitches. So trying to keep those patients separated if we can. We want to have a better medical screening area, basically a place where we can triage patients and, again, protecting their privacy as we do that. We want to have additional exam rooms. At this time, we're kind of sometimes expanding beyond our 5 rooms and having to put patients in hallways or into our, our little break room. It just doesn't look very good to patients. So try to expand our rooms a little bit. Separate our 2-bed trauma room into 2 separate rooms so we can have 2 trauma bays that are, again, for privacy. Provide a behavioral health holding room. We've just seen a significant increase in need to have a place where we can put behavioral health patients in a nice, safe environment. Provide better visual for our nursing staff from their nurse's desk, and they're out in the rooms all the time. But when you're trying to do some documentation on the computers, that you can be able to see all of the rooms at one time. A drop-off canopy, obviously, so that we're getting out of the weather when we have patients coming in. Registration, at this time the registration is pretty much off to the side, and they're really separated from the nursing staff, and there can be some times we have some scary people, so it'd be nice to have that right backed up to the ER, to the nursing staff, so they can have that, each of them backing each other up, so having that a little closer. And then, again, back to the privacy of having that increased privacy when they're registering, so those are some of our high-level goals for the project.
So as part of the application, we had to provide a tentative plan of what it is. So here's the existing ED. We would remodel this area and possibly expand down to there. Gives you another idea how the current layout is. The trauma rooms are here. We have the 3 treatment rooms, registration. Shows you how we would be expanding and increasing the size with a high level layout of what it may look like. This is tentative. We do have to have detailed design and come up there, but kind of looking outside, how we would change the entrance to potentially off of 12th Street, still have room for MRI. They would exit this way, entry here in the canopy. So again, they're high-level ideas. We have to go through the detailed design. So as part of this, we had to name an architect, and we took the opportunity to evaluate to ensure we have the correct architect for the project. We offered interviews to 7 architect firms, 5 accepted. These are the 5 that were there: Altus Architectural Studios, RDG Planning and Design, BWBR, Shive Hattery Architect and Engineering, HDR. Our interview and review team was all senior administration plus Drew Becker. Through all of the processing and discussion and everything, Altus Studios came out on top. They're an Omaha architect firm. They focus only on hospital and clinics, and actually it's about 98-99% of their projects are hospital and clinics. They currently have a project in Shenandoah in the Cancer Center. They did the hospital replacement in Beatrice, Nebraska. They also had a huge project over in eastern Iowa in Dubuque, $25 million cancer center. And actually the parent company for Mercy, they're doing a $50 million project right now. So our programming and our conceptual design is that first step to validate that layout that we had come up as part of the application and to get that high level, what is the cost going to be? It's kind of the step one. The estimate cost on that is $22,550. Total fees are between 8.4 and 8.8% of the entire project. So we estimate that to be in the neighborhood of $375,000 total. We won't know that number until we start to get into the schematic design where we do have that specific layout, and that is what we're going to design to. But the next stage is after conceptual design or schematic design development, construction documents, which is the documents that go out for bid, and then construction administration, once the construction starts. We have to have, by USDA, a contractor named within 1 year of notice of receiving that award, which should be January 28th, but our goal is to have that named yet this calendar year. And then obviously our construction to begin when the ground allows us in early spring, and then continue for the next year to year and a half. So we would like your approval to move forward with an agreement with Altus Architectural Studios for the ED expansion and renovation projects, and would entertain any questions you may have.
Are those fees consistent across all architectural firms, or are they, how does that?
They're kind of right in the middle to the low side. We had fees from about 8.5% on up to close to 10% for the same project. They're all based on the dollar amount of construction, so as your dollar amount for the overall project construction costs go up, the percentage goes down, but your fees then slightly increase as the project increases.
And that's based on a $4 million project?
Roughly a $4 million project, yes.
Are there any other questions before we? Okay.
I would move that we enter into the agreement with Altus for the ED expansion renovation project design.
Thank you, Terry.
I'll second it.
Thank you, Jim. All right, we have a motion and a second on the approval of the contract with Altus. All in favor, say aye.
Aye.
Do you think they'll have any problem getting it completed by, is it January of 2024, or is it end of year 2024?
End of year 24. You know, we've been using December 31st as that completion date. They have about 3 weeks beyond that, but as of today.
So you're saying that if they don't get it done, they get till third week of January to finish?
Yeah, that is a contract by the USDA. It's 3 years from the award date.
Is there extensions if we need to?
Blizzards.
I am not 100% sure on that. That is, USDA is very, very involved in the whole process, and we have to provide monthly updates, and they have to be involved in all the meetings. So that is something that I don't know how to answer right now today.
All right.
All right, great. Did you have anything else, Barry, before we move on?
I don't, but we are going to defer the Peterson Family Wellness Center dehumidifier.
Oh, okay, all right.
We're still talking to another vendor. Would like to hold on that for now.
Okay, that sounds fine. All right, so then Christy, it looks like you're gonna present waiting room furniture for us.
So we've been talking about this for the last year or so, and had some, with COVID, it's been a little bit difficult to get bids and companies to come out and look at our furniture. But our main concern is down in the corridor, down by outpatient services. The furnishings have just really taken a beating with all the cleaning due to COVID, and they're approximately a little over 8 years old. I think it was right before I started here that that area was renovated. So you can see there the tables have lost a lot of their finish on the top. The chairs are cracking. They're just not very attractive, and we get a lot of patient comments about them. So we went out to bid, took a look at 3 different companies, and the MSS Contract Furniture was the low bid. And this is just some examples of what we would get. So we're looking for furnishings in the upper level of the rural health clinic, the lower level of the rural health clinic. We are going to do a little bit in that information desk area, although we've talked about the gift shop going there, but we have some office furniture that we would like to have some of the chairs to match the rest of it. So we'll put some chairs in there to match so we're consistent throughout that whole area down there. And if we move forward with the construction of the gift shop there, we can utilize those chairs in other areas that had requested additional chairs. So they won't go to waste. And then the whole court, well, I can go through this. So this is just an example, and you can't really see in the picture, but we're gonna go with for the clinical areas, we're gonna go with a lighter back on the chair and a kind of a tan. It picks up both the gray concept that we have here and the renovated out here in this hall area and the browns that are in the other. So if we transition to gray other places, they'll still fit in. That was one of our main goals there. Had EVS look involved in the process so they could look at the fabrics and the vinyls and make sure and discuss with the representatives that they would be able to be using our cleaners that we currently use and hold up. The little just down here for administration, Barry's chairs, my chairs, and the ones in our office is really what we're looking at there. We're going to kind of go with a bluer, darker color there. So this is where we are. So you got the clinic waiting area up there on top. So that would be the downstairs clinic area. Do I have a pointer here?
Yeah, the red.
Okay, so this is, I believe, the downstairs clinic area here. And then this is the upstairs clinic area, what it would look like, just pretty much similar to what we have. They drew our offices, having them all out in the lobby, but we would be splitting them up between our offices and a couple out there by Ruth. So this is the outpatient, area right across from registration. We're replacing those, this surgery wait area, and then all along that corridor where that furniture was that I was showing you. Just another view of it. You know, chairs, this is the way it's set up now, chairs on both sides and a little love seat in front of the window. Diagnostic imaging, they have a small waiting area behind their doors. Again, that's what those looks like. And then across there from the lab drawer rooms, that furnishing looks pretty bad too. So going ahead and replacing that little bit of furniture. The other areas that came up I don't have pictures of is PT. We went ahead and looked at PT. Their furnishings are wearing too, so we'll go ahead and get PT's furnishings over there. I believe that was it.
Are these the same things that are in the new north entrance?
It's similar to that over there. That was purchased from Staples. Staples did give us a bid, but it's the same furnishings brand and models that the MSS gave us. But yes, the chairs will be wood based, but they'll have the black
Bingo. That's the best
arms
stuff.
on them, like that's covering the wood down in the west waiting room. So that's, you know, a lot of our wear and tears on those arms, so they will be black, probably urethane or
Yeah, it's a
whatever they
vinyl
call it.
covering, arm covering.
Yeah. So, and these chairs can be, you know, if a seat rips or something, you can pull the seat off, reupholster it. We've talked about maybe getting a few yardages of the upholstery just in case we have that happen, because we're not buying any more than what we really need, but maybe having some backup. So Jim was going to check on that. So our bids came in, MSS came in at $97,536 with freight included in that. Duet was our other bid. They gave us two different options of two different grades of furnishings, and they ranged from $111,000 to $118,000, but that did not include freight. Staples, which is the same brand, same model as what MSS gave us, that was $101,000, and that did not include freight. There's a little bit in there to, I think it was $4,700 $4,800 in there for them to come in. They uncrate the furniture, they assemble what needs to be done, and then they take out what we have and put it into place. So since there was so much assembly of the chairs and stuff, we went ahead and just left it. Our maintenance staff is busy enough, they don't have time to do all that in those areas. We are checking out different options of what we can do with our old furnishings. We'll save the best of what we've got and use it other places that have that furnishing. Otherwise, Prison Industries, Iowa Prison Industries does have a rehabilitation division of their furniture. And so we're gonna check and see, maybe they would wanna buy it or take it off our hands and refurbish it and use it for their program. So the recommendation is for the $98,000 freight included from MSS. They have 8 to 10 weeks of delivery. We do have phase 4 COVID funding, federal funding, the Americans Recovery Funding. That is for mitigation and controlling COVID. So this is definitely an infection control project, having that furnishings in better shape. So we can use that funds for payment of this furnishings.
Any other questions? So had you actually, excuse me, seen a piece of this?
Yes, there was a lovely, with some lovely orange plaid fabric that was down in the
In the 70s.
Yeah, so yes, the department managers that are involved all reviewed it, has reviewed the plans
Okay.
and we're comfortable with it.
Nice and comfy.
Yeah.
Any other questions, board members? All right, if I could get a motion on the approval of the waiting room, well, it's more than waiting room, furniture replacement, but furniture replacement.
I would. I'll
Okay,
second
Kelly?
that.
Thank you, Terry. We have a motion and a second on the furniture replacement. All in favor, say aye.
Aye.
Opposed? All right. Christie, I guess you're just gonna keep us entertained.
Okay, so our condensed financial statement for February, this is a little bit different. Two different things here. Okay. So anyhow, the year-to-date isn't up here, but I did note last month that you guys did talk about, wanting to see where we were pre-COVID. So we did do a February comparison. So this is year-to-date comparisons of February of 2019, 2020, 2021, and 2022. So it kind of shows you there that most everything dipped in that February of 2021. Hadn't quite hit COVID there. It really hit us more in March. So we went from 39, almost $40,000 visits in year-to-date in the 7 months of 2018, 2019. All the way up to 45,000 there as of February 2020, back down to 43, and we are exceeding that February 2020 there, just as Kim had said, at 45,714. And that, of course, is outpatient behavioral health visits. ED, you can see there also, it's 3,590, almost 4,000 in 2019, went to 3,800 in 2020 and went down to 3,000. So ED was one that took a bigger hit during COVID. But we're back up to exceeding where we were pre-COVID at 3,912 visits in the 7 months.
Why, might be a stupid question, but I've not ever understood why emergency would go down in a pandemic. It's like if you have an emergency, it doesn't matter, right?
Well, that's the way you would think, but I think we see a lot of people who use the emergency department as their clinic.
Oh, well,
So those people who are not going to the clinic, those people who are not using the clinic.
On the weekend, it can be an emergency care,
Yeah.
versus another city, where you need to see somebody. You don't want to wait till Monday.
well, and it has to be, because I know it's like national trend, it went way down on emergencies, so.
Is there COVID money in that year-to-date stuff in 2022?
Yes, in 2022 and 2021, there's some COVID money that came in there in that non-operating net there.
Uh-huh.
Yep. So we received additional funding in, it's been November, I believe, that we got an additional allotment of $1.4 million. So again, surgical procedures haven't bounced back. We were above 1,050 there roughly in 2019. We're at 938. The clinic visits, as Kim had said, they're 31,000 to begin in 2019. Dropped in 2020 there and dropped even farther in 2021 down to 26,600 for the 7 months. 31,278 is where we are now, so we're slightly above where we started back prior to the pandemic. Average daily census, we've stayed really pretty consistent down there at 10, a little over 10. We're at 10.65 for as of the end of February 2022, so staying there. Births, we've gone from 42, 50, 30, and up to 53. And our operating income there, you can see it's pretty much stayed consistent, even though our services were down in February 2021 for those 7 months. Our revenues were about the same, so it just depends on your service mix there. And then our expenses have gone up. We've had to do a lot with retention, retainage, trying to keep staff here. Supplies have gone up significantly in costs. And also, without having the staff here, we've had to pay for traveling staff, which is a lot more expensive. So year to date, for the 7 months ending, you can see we went from 200,000 to 353 to a loss of 683,000 in 2021 February, and we're at 346 so far this year from operations. Other non-operating income, we're at 2.9 million, and again, some of that is COVID money, about a little over half of it there. And from all resources, we're at 3.2 million this year. In 2019, we were at 1 million. 2020, we were about 1 million, and 2.8 in 2021, which also included additional COVID funding there. Any questions on the condensed financial report? I did take a look at the balance sheet. Of course, we're always watching that. Our balances are still enough to support what we need to do to operate the hospital. Accounts receivable is coming down a little bit. We are at, between combination of HB and PB, which is our professional and hospital billing, we're at about 55 days. In November, we were at 67, so we've come down quite a bit. A lot of that has to do with our coding staff. The coding staff is not out there. So we're using contract coders, which makes it a little more difficult and it is more expensive. So finances and the financial report still looks very strong. Any questions?
I'll make a motion to approve.
Okay, thanks, Jim. If I could get a second, please. Thanks, Tom.
Thanks, sir.
A motion and a second on the approval of the monthly financials. All in favor? Aye. Payroll and claims been presented to all of you. If there are any questions for Christie on that.
I move the approval of the February payroll and claims.
Thank you, Terry. If I could get a second. Thanks. We have a second, Kelly. Motion and second on the approval of payroll and claims for February. All in favor?
Aye.
Opposed? All right. That brings us up to our adjournment. Need a motion on that, do we? Do we use a motion on
I'll
that?
make a motion.
All right.
I'll second.
Jen's anxious to get out of here, and so is Kelly. Motion and second. I guess that concludes our
Do you want to vote?
business. Oh, yeah, you want to vote on that? Let's go.
Aye.
Sorry.